To also start recording with Zoom, not just the Read AI recording. I'm remembering today.
Woohoo. Morning, Logan. Thank you for joining us as well.
Good morning. Of course, thanks for having us.
Of course, of
Absolutely, our
course.
pleasure.
All right.
How are you doing this fine morning, Logan?
Not too bad, not too bad. Finished the OSCE and everything yesterday, so officially on some semblance of winter break with step two or step one still on the mind. So sort of a break, but definitely doing okay.
There's no real breaks in medical school, right?
Yeah, exactly, exactly.
They're
So
like, you don't have lectures for these next couple of weeks, so there's this other major thing you should get done right now.
yeah, exactly. It's all about like shifting the work around, you know? So,
Mm.
but hey, I'll take the no lectures part. So
Yeah. Absolutely. So that was also my goal for today was to not lecture for 3 hours.
awesome.
Not gonna lie, it's just my default go-to. My first plan was like, I'll walk them through my 40-page book. And then I was like,
No. Just,
Brandon,
just, just,
no,
no, no, no. Bad
no,
Brandon.
we don't want to do that. So thankfully I've got AP here, short for Andrew Paul, to co-host the event with me. This is a pretty cool dude from Forbes 30 under 30.
Oh, psh.
Toastmaster. So yeah, I'm gonna have some fun with it. All right, we'll give it a few more minutes, see if we get any other folks joining us from the start. Otherwise, we'll just get the ball rolling and folks can join us as they're able to. The main way that we're going to progress through the discussion today is just going to be a series of polls to our participants here to kind of get a vibe check at the start of each subsection. And we'll use that to sort of center the discussion for each of those subsequent portions. So that was my idea for it. So essentially, your guys' responses in the polls today will be what shapes our conversation. And I will just be essentially providing as much of my advice and things that I've used to help coach students to success on step one, step two CK, um, before that, MCAT. I've been doing standardized test preparation for 19 years now. Most people don't believe that because they think I look 19, but I am in fact 38 and started doing this when I was 19. So yeah, that's just, the good old Kaplan way is to find Kaplan students from their courses who did well and then say, hey, do you want to try being a teacher? And so I'd taken a Kaplan MCAT class and they offered me that opportunity. Went through their teacher training for 6 weeks, and I was the only one of my group of 9 to make it through. And that's when I realized there's a big difference between understanding content and being able to explain it well to other people. Because I was like, oh, the other 8 people in this room all were like 90th percentile scores, and none of them could explain this stuff worth a darn. So that's when I realized, somebody being a high scorer doesn't necessarily also translate into them being a good educator. And so I did that with Kaplan for 5.5 years before I got into medical school. Because I didn't get in right out of college. I was really young when I applied the first time and also applied only to the top medical schools across the country because I was so confident. And then I was resoundingly rejected and decided to go actually grow up for a few years. And I got my EMT and paramedic certifications. Went around to psych facilities and people's houses and jails and wherever else they sent me into and just learned to deal with the situation that was happening and, figure out to the best of my ability what was happening at the time. And I think that really translated into how I approached learning medicine in medical school and how I nowadays translate to teaching my students, which is prioritizing clinical reasoning as early as possible in your medical school education, not treating things as just more and more facts to memorize, but really trying to build your conceptual framework of how everything works off of a solid understanding of the normal. This is the anatomy, this is the physiology, this is the embryology of how it develops. Then let's look at the pathologies and the pathophysiologies that lead to aberrations of that normal. And then let's think about how the treatments can either fix those aberrations or at least attenuate the symptoms that are a result of that. And once you kind of build your system knowledge in that order, just normal, abnormal treatments, everything else, it really makes a lot more sense. So that's just a little advice off the front end of how to work through each system while we're waiting for other folks here. But let's go ahead, AP, and we'll just get the ball rolling today. And yeah, folks can join us as they wish. And Logan, Ryan, you're welcome to drop notices to other folks too that they're welcome to come join us. But I don't want to just keep spamming y'all's Discord. So,
Sounds good. All right, Deason, you want to kick us off with the first poll question?
yes, sir. All right. So, our first pulse check of the day here is how are you feeling going into dedicated? And we've got some options of excited, overwhelmed, ready, behind, and numb. All right, so we've got our responses here from our two folks going right into dedicated. One's feeling overwhelmed and one is feeling behind. And those are, I think, similar symptoms there. And that is common. It's very few people are excited to go into step one. Those people I think probably have their own diagnoses that are different from my own. Ready would be a great place to be. And I'm glad to hear neither of you are feeling numb because that is the least ideal place to be.
Hmm.
Overwhelmed and behind, though, that's normal, normal feelings. And we're going to be addressing that today through really discussing how to set yourself up well from the start with knowing what you're going to be doing each day, but also just how your schedule is going to progress as you move through the weeks between now and test day. So one
Absolutely.
thing I really like to try and help our students with is, breaking it into phases or 4 stages, and we'll get into that some more in a little bit. But essentially, what you're doing in your first couple of weeks, day in and day out, is going to differ what you're doing day in and day out later on closer to test day. So the first thing to understand is there's no right answer to like what you should be doing every day, no matter where you're at. You want to calibrate first where you're at versus where you need to be. And then we'll talk about how to figure out of the range of resources that you have, which ones to focus on in each of these stages. So, thank you guys for your responses to that first one.
I guess where we delve in a little bit decent, for Ryan and for Logan, and of course, good morning, Remo. Thank you for coming. Like, what's kind of the overwhelm slash what's driving that feeling for both of you guys? So I know that medical school is obviously there's a lot of moving parts between clinical work, your coursework, volunteering, and trying to balance the responsibilities of life on top of that. But tell us a little bit more so we can better help you with that.
Yeah, I can jump in first. I think for me, one of the feelings of being behind is partly because a lot of like my classmates have already taken step. I know a lot of them took it early this year. I think like it was something crazy. Like someone took it in June, I want to say, of
I
this
did hear
year.
that
Like,
story.
yeah. So that could also play a role on why there's less people here today, just because my class might be overachievers and already done. So I think in that sense, though, like a lot of us have talked about, like a lot of the people who talk about STEP are those who have already taken it. So
Mm,
then when someone like me, I'm very much so like, all right, I'm going to study over dedicated, take it early February and
right.
just be on track, almost feels behind now. So
Mm.
I think that's kind of where I'm at and what that answer choice kind of stemmed from. So
That is a really good insight. I appreciate that, Logan. And I think that that's something that is something we can't help but do in medical school, which is constantly compare ourselves to whoever's furthest ahead. And it's more natural for each of us to be able to sort of brag or not even necessarily try and brag, but just talk about where we're at when we're way ahead. And so you disproportionately hear from those folks, and it makes you feel like that's the norm. And instead, where you're at is the norm. You think of the bell curve, you're hearing from the folks up here in the front tip. You're definitely not going to hear too much from the folks in the back unless they're just really the people who are like, don't mind being vocal, like, hey, what the heck? I'm getting left behind here, guys. Help. But yeah, I would say most students are right where you're at, Logan, but feel like you feel. And that's something that I really try and number one, just with all of my one-on-one students, is setting the norm of you are the norm. Like going through, at the beginning of your dedicated and making that your dedicated time to study for step one and taking it during dedicated. That's the normal thing to do. That's what it was built for. So I think, one thing that I did realize after step one is I wished I had been one of those folks who like paid attention to first aid throughout the first year and a half and what in lecture was most important for step one, and perhaps had resurfaced that content more. But otherwise, really what it's going to come down to for each of you is going to be we'll talk about where your baseline is at versus where you need to be to comfortably pass step one, and what milestones you're going to look for along the way between here and there to make sure you're progressing appropriately. Because I feel like it's really easy with step one, especially if you are feeling behind or you are feeling overwhelmed, to just constantly be questioning if you're doing the right stuff each day and whether you're spinning your wheels or making real progress. So that's just some additional thoughts I have on that off the cuff. Kick it back to
Sounds
you,
good.
AP.
Sounds good. Anybody else? Ryan, I think you also had a response as well, if you want to share with us.
Yeah, I mean, I can't really say it any better than Logan said it. Obviously, when you see people around you and they're being, they're ahead of you on that bell-shaped curve, it is nice to know that there's people like Logan and people like me that, haven't taken it yet or in that similar situation. But I think that's when the overwhelming feeling that I described just kind of comes in where, you know, we're not at that side that we would like to be on. And obviously, in medical school, we're all people that want to be high achievers and want to be on that side of the curve that's already done. So yeah, that's where my feeling kind of stems from. But I guess we kind of already addressed it.
Thank you for the your added thoughts though, Ryan. So yeah, we'll delve into that a little bit more as we continue through the day. But AP, you want to pull up our second poll of the day?
Absolutely. Do 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 do. Get rid of that one.
We just
All
figured out
right.
how to do polls and quizzes in Zoom yesterday.
Ba, ba, ba.
All right, so this one's a multi-choice one. So there's a lot of information out there, as I'm sure you guys have already heard from classmates or seen on Reddit or Student Doctor Network. And we're curious to hear what would be some factors that would make you trust guidance the most.
I'm on mute. Here's what we got, bud.
We've got one of five, though, have participated here, so we didn't close the poll yet, did we, AP?
Hold on. Wait a minute. Wait a minute.
I think you
Give me
got
one
too
second.
excited, friendo.
I think I might have gotten a little bit too excited.
Yeah,
I don't know
one
how it's possible
person,
to get
it's a multi-select bud, so one person
ah,
selected multiple things, but you could see at the top it had said one of five had participated.
okay, that actually is very smart. Okay, guys, we just reopened the poll. My
Okay.
B.
All right, go ahead and re-answer, folks. All right, there we have three of five participated. That should be our three medical students now.
Sounds good. All right, let's rock. Let's see what we got.
All right.
Boop.
So this was my kind of tongue-in-cheek fun way of instead of giving the bio of myself, these are all things that describe me. Ha ha ha. But I did go to U of A Comp. I graduated 2016, so started 2012. Um, I did pass step one during my dedicated. It was on a numerical score for me, still back in the day. But I was not somebody, Logan, who took it in June. Um, I had made the decision to start medical school and have a child at the same time. Hindsight, I don't know why, but my son was born orientation week. So I was always playing this balancing act, through medical school of trying to be what, I epitomized as the good present father and to be the good present, well-achieving medical student. So I was not one of the people who soared through it, and I actually don't mind sharing that I failed a practice test like 3 weeks before my scheduled date. And, they were like, you really got to get your stuff together if we're going to allow you to take it. And so that was when I had first reflected. I had already taught for the MCAT for 5.5 years. And I was like, what am I missing here? Like, big picture. I know how to take exams. I taught students how to do that specifically. And that's when pivoted away from the memorization and started developing more of the strategy and approach that I now teach students today, which is treating the questions like patients, one at a time, one line at a time, and thinking through it clinically. And the good news is that since I took the exam over the past decade, it has shifted more and more towards that style. And you can see that in the more recent NBME exams versus the older ones. You'll see this shift from testing, do you know this kind of stuff, to can you reason this out based on the information that you're given. So, one of the things, I'm just going to throw this in here now so that I can say it early and often, is breadcrumbs, not buzzwords. One of my favorite little sayings I made up is forget buzzwords. I mean, well, don't forget them, Every now and then they show up. Like you should know what a bird's beak appearance is. I'm not saying that, but you can't rely on that to show up that's going to be there for achalasia every single time. Rather, you need to learn that every question here is written by someone like myself who is giving you a 1 minute story. that's leading towards one correct answer in this case. So, the other thing I like to mention, this isn't real medicine. Nobody's going to be like, Logan, go see this patient, and then in 60 seconds, tell me what's going on. But that's what we're getting tested on here. So keep that just as a nugget in the back of your brain. Every single line is there for a reason, and we'll get more into this later. But the rest of this stuff, also all things true about me. So real quick, I mentioned before, I taught and tutored for Kaplan for 5.5 years before medical school. Upon graduating, I did match into the EM residency of my choice, lovely Hahnemann Hospital out in Philadelphia. Had some health stuff going on. My kiddos were special needs. I was on leave of absence, and then the program shut down because the owner didn't feel like he was paid enough money, and 600 medical students were displaced. Many were able to go and find new residencies and relocate again. Um, I had just gotten my kids officially diagnosed with autism and speech apraxia and into services at CHOP. Like, and I was just like, no, I'm not moving again. So I made the choice to go back to Kaplan at that point and got into content development, which quickly led to content management for me. And that's when I was able to, move from tutoring and teaching to somebody who made the MCAT 7 book series largely what it was for 4 to 5 years in a row. And I'm still in the credentials on most of those, just buried down now under the current people. Um, I've been doing this for 19 years, but my whole thing is that I'm here to help students think like a physician. It's not just about passing step one that matters. I'm here to help you start processing how you're going to treat patients with a differential in mind and work towards the most likely diagnoses and how you would present that back or summarize that at least to yourself as you're working on questions. But that lays the foundation for how you're going to summarize and present to your residents and attendings. And my methods serve an amazing foundation for Step 2 CK. Um, the best one I've had to date is somebody who I had helped just pass Step 1. They came to me 3 weeks before their test date and were like, okay, band-aids, 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 band-aids. You passed. Yes. But then she used my methods to study for the entire next year and scored 48 points higher on Step 2 CK. And was able to match into surgery, and she's now a surgery resident. So that's what I'm really here about. The last one I threw in there just for some fun as well, but student outcomes above profits is something I kicked off that I call my SOAP notion. And that's really the foundation of my business is I've built minimal profit margins. I walked away from a salaried job at Kaplan and I make enough money off of you all to pay the bills each year and then develop resources with the remainder of my time to help students navigate the main pain points of medical school. So that's all I'll say about myself. But I like to just at least give some context where the advice is coming from. It's truly just I want to help, and this being for my alma mater, as I mentioned on the Discord, it's just my personal goal to see nobody else have to fail or get left behind on step one from our school. I've helped students over the past few years who were behind and who did fail on their first attempt. And I have helped every single one of them who came to me retest and pass. But I don't want you guys to have to get to that point first. There's inevitably, that bell curve of folks. There's that tail end as well. And I just want to help move you guys up into that main bulk of people who can get through this during dedicated and stay on track to start rotations on time and not have to worry about if the first 2 years are going to go to waste or if you're going to have to twiddle your thumbs for a year to pick up rotations with like next year's class. It was a position I narrowly escaped myself. Like I said, having failed a practice test 3 weeks before my test date, I was in the mental place of like, is this where I'm gonna be in one of these other two situations? And having pulled myself out of that and helped pull in other students out of it, I just don't want you to have to get there in the first place. It's a crappy place to be mentality wise, and nobody needs it. All right, AP, what do we got for our third poll, my friend? All right. Yeah. Which performance constraint or constraints are you guys most concerned about? So these are all things I have felt myself when I was going through step one and step two CK prep and situations I've helped all of my students through as well. One thing I really like to emphasize is that success on these exams comes down to knowledge, skills, and attitudes. So this is learning science stuff that I was taught originally on a fourth year medical education elective. And it's something that I have used as the foundation for all of my services, is that there's a certain amount of knowledge you have to have for success, but then there's also a skill set, right? You guys have already seen this. You can read the books and watch the videos all day long, and then medical cases pop up, and it's just a different thing. It's not just a straight, hey, you watched this and took some notes. Can you answer the facts? So you have to recognize that it's a skill set to develop all on its own, which takes some time. And the attitude portion is knowing that, like, what it's going to look like to work through it. And that's something that I really try and help contextualize for my students. So this is a standardized test, not an academic test. Does does anybody have any thoughts on what I mean by that? I'll kick it to my co-host. AP,
And
you work in this industry. What do I mean by a standardized test versus an academic test, man?
I mean, here's the thing about standardized tests, right? There's a level of knowledge that you need to come in with these tests, be it the MCAT, be it step one, step two, or step three if you USMLE, right? But because it's a standardized test, there's a level of thinking, there's a thought process that the test makers want you to be able to emulate and reason with the knowledge you've acquired through your clinical rotations, through your textbook studies at medical school in order to succeed on this test. So it's not just enough to have the knowledge, which you need to in order to pass this test, absolutely, but you need to be able to have a thought process as well in order to do well.
Yeah. All right. And then here's a couple of other caveats that I always like to stress to my students. So I never worked for the official exam makers, but for 2 years while I was at Kaplan, my job was what they called MCAT test likeness. They came to me and said, hey, students are saying that our full lengths don't feel like the real thing anymore. They've made changes and our stuff feels out of date to students, and we're not exactly sure how to fix that. That's not just some, make the full lengths feel more test like. So, what I ended up doing when I took over that project, the trick was Kaplan had 11 full length practice tests, and the AAMC only published four practice exams. So, how do you make 11 practice tests that feel similar to four? You can't just like copy the content off of those four and like repeat it over. So it was really, that's when I learned how to identify underlying patterns in terms of the way that a standardized exam tests content, the skill set that's required, crossed with the knowledge. And then there's the fact that the reason I said it's a standardized test, not an academic test. Academic test is designed to just set a bar that you need to get past. A standardized test is supposed to create a bell curve for the students by definition. And to create a good bell curve, does anybody know what the average has to be? You could drop it in the chat. Where would I want my test average to be to get a good bell curve on this? All right, I see 70 from Ryan, 60 from Rima. Yep, you guys are right in the vicinity there. So a 65 to a 70 is what I want my fully prepared test taker to score on my exam. So that's what you're aiming for to be able to comfortably pass step one. 65, that's like the low cutoff. 70, you're going to be passing every time. So that's number one, how I have to set like the parameters when I'm trying to create a test on the back end is I want to create an exam where the average person who's prepared is going to get a 65 to a 70, but that's not good enough. To create a bell curve, I have to be able to differentiate between the folks all along that. I have to be able to tell apart, I'll just switch to a numerical scale. Passing step one is typically like a 195-ish, last I had checked. But I have to be able to tell apart somebody who's a 185 from a 195, from a 205, from a 215, from a 225, from a 235, and so on. Which means to differentiate between people all along this spectrum, I need to create questions on a difficulty range all along this spectrum. So, number one rule for you to take away from this is that not all questions are written at the same difficulty level. There are meant to be really easy questions on USMLE Step 1, as well as really, really hard questions that nobody's really supposed to get. Your job as the test taker is to try and get through the block fully and pick up as many of the lowest hanging fruit for yourself as possible, recognizing there's always going to be a certain percentage of questions that are on oddball left field topics, and there's always going to be a certain percentage of questions that are topics but the hardest difficulty of it. You can still miss diabetes and hypertension questions on test day if they're written to be the hardest question on that block. So that's just a couple of things to keep in mind. Now, with the rest of this stuff, that's what I would love to talk about. Most of you guys are concerned about not knowing what to do each day, actually doing it and getting that foundational knowledge in place, as well as burning out and losing motivation. So, before I expand on that, let's actually pull up poll 4 AP because this is, I think, the crux of the issue. I am curious what resources you guys already have at your disposal and are planning to use. And I just listed 15 options here, which is far from comprehensive, believe it or not. And I'm curious if you guys can just type in the chat on the side a rough estimate of how many total resources you think you're using or will be using as you go through the step one process. Okay, cool. I'm seeing in the side chat 4 or 5, about 6, also around 5. And I'm glad to hear that because believe it or not, like I interviewed 100 students on this a couple years ago, and the average then was 6 to 7, and it's crept up since then. And a lot of the students I've seen coming to me now already have access to 8, 9, 10 resources, and sure, lots of great information at their disposal, but then they sit down and they're asking themselves, that first issue that we had in the last poll, which is like, what do I actually do each day? And how do I know that I'm like effectively getting towards the end that I want? And I'll see these students study for 2 months and then be like 20% of the way through 8 different things and wondering, why they're not bringing it all together yet. So, number one is avoid the resource overwhelm by, you can poke around at 8, 9, 10 if you want and see what they look like, but then you need to pick the 4 or 5 that work best for you and focus on getting through those.
I guess a quick question for the folks in the audience, for Ryan, Logan, and Rima. How do you guys choose what resources to get? Because again, medical school student, right? So y'all got a lot of things to do, not a lot of time to do research. Like, what's that thought process for you to select those 4 or 5?
Yeah, I can jump in. Our school gives us UWorld, which is nice. So UWorld's a given. And then the NBME exams are also kind of a given, just working off of those. And then Anki is definitely big at our school too. Like we have an optional tag that's thrown in there. So we like our lectures are tagged with step one content that overlaps. So that's helpful. And then the other ones are kind of, I feel like word of mouth, at least for me. And then one that I always like is also like the Divine Intervention podcasts, because I really like the podcast resources, and there's just not a lot of like true good medical podcasts out there that you don't need to be like looking at something while you're doing, and you can like be in the car or getting work done. But so I think that's one of the few, the Divine Intervention podcast is one of the few where I've like tried to look for it and I saw someone mention it in the Discord and then found it through there. But
Awesome.
Awesome.
That's really good to know. Nobody picked DDQX Learning Trivia and High Yield Tables yet. That's okay. I just launched those a few weeks ago. Um,
Let's see. Rima,
Trying to
what did
figure
you
out
say?
how to make more stuff that would be useful for you guys. I have created about 10,000 trivia questions for the DDQX Learning Discord that drive at the core concepts that you need to be able to know and the facts that you need to know. But I think we don't have it organized well enough yet. It's just too general and too broad, and people are like, I don't know what I'm actually getting out of this right in the moment. But we'll keep
Let me
working
see.
on that. But yeah, that's
Rima
what
said,
API had
oh,
thought as well. Like I had mentioned to you, a
mhm.
lot of resources, I think, for US medical students are a certain subset are provided as part of like,
Yes, I did. I also noticed Rima did say, usually talking with others and comparing vibes, learning styles, and then spending like a week trying to trying something out and saying, got you. So a lot of word of mouth and being like, this is actually work because it would just not, because there's a lot of ways to learn, right? There's,
Mhm.
of course, the podcast way of doing it, flashcards. Like, I don't know any med student or pre-med student out there does not know of Anki. Like, I think that's probably like something that's pretty entrenched in the community. And then a lot of just kind of hearing what other students are working, because I know Sketchy is a lot of like for visual learners and stuff like that can be very helpful.
One thing I will say with regards to Anki is make sure you time cap how much goes towards that. It can be very helpful for the spaced repetition and drilling facts, but again, there's a skill set that you have to develop through practice-based learning that requires doing actual cases and seeing how it's applied. And I've seen plenty of students who, in trying to memorize all the facts, end up in what I call an Anki hole, where they're like, it's telling me I've got like, all these cards to get through every day now, and it takes me 4, 5. I even had a student who had been spending 6 hours a day getting through Anki cards, and they weren't making score improvements, and they couldn't understand why. And because you're not getting into the practice-based learning. So what I recommend is we're going to move in this next portion here, guys, through my 4 stages to test prep. So what you do in each of these stages as you get closer to test day is going to vary. So let's go ahead and kick off poll number 5. Oh, and shout out there to Sketchy as well, who had 3 out of 3. Um, I know they have been incredibly popular, especially for micro and farm. I always hear about sketchy farm and sketchy micro. All right, so there are all these great resources out there, but at the end of the day, you need to get through questions as well. And so I'm curious, what do you guys think the biggest barrier to getting through enough questions is? How many to do each day, feeling like starting late and running out of time, getting discouraged by the low percent correct. Yep, yep. I feel like this is a lot of what I continuously hear from my students. And that's why, as we go through this process, y'all, um, we really want to think about what you want to focus on with each of these. So I'm going to go ahead and share my screen. So I'll be sending out to each of today's attendees a Google Sheet version of the study plan and how to move through the different stages. This here is Coda, a software that I use for my one-on-one students to walk them through this. And so essentially, the first 20 to 30% of your total study time should be really focused on capturing the core concepts, making sure you have that high yield conceptual foundation in place, which means, going through your biochem foundational stuff, your micro, your path and farm, making sure those general principles are all making sense to you. And then you are going to want to go through that highest yield content for each of your major systems. So when it comes to the systems, I recommend starting with cardio, then pulmonary, then renal. While USMLE or NBME doesn't group them this way in terms of the topics, if you put these 3 topics together, cardiopulmonary renal is going to make up about 20 to 25% of every one of your exams. So for me, a strong CPR game pulled me through any set of, random questions I would face that day. And so as you move through each system, you want to focus first on the normal, then the abnormal, then the treatments, and then everything else that, is ancillary to that stuff. But cardiopulmonary renal is going to be your big 3, GI, neuro, endo, and repro, and you're at your 70% of the exam right there with those systems. Derm, optho, histo, love you guys, but you can get by on those. with your best guess without having to spend a ton of your time there. So get that foundation down. Then you're going to want to focus on increasing the amount of practice questions you're doing every day. So no matter what, rip the Band-Aid off, and you should be doing UWorld questions every day right now, at least 20. But then as you have gotten your core concepts reviewed over the first couple of weeks, you're going to want to switch gears to doing more questions and then using the review of those questions to determine what topics you need to patch up. And essentially, you're just going to want to make that a transitional process between your, let's say we're on an 8-week study plan here, guys, doing 2 weeks for each. We're starting off, we're doing 20 questions a day here. Through this portion, we're doing more of like 60 to 100 questions per day. And then with the pacing and endurance, it's about moving up the number of questions you're doing every block. So you want to get up to 20 questions at a time, 30 questions at a time, to eventually your 40 questions at a time. And then can you do a couple of those blocks in a row? So early on, questions per day can be less. My students near test day are doing 120 a day, and it changes. We do 40 questions in an hour, break, 40 questions in an hour, break, 40 questions in an hour, then review the full 120 for the pattern. That's the other big shift you're going to want to keep in mind. It seems slower early on. You're doing less questions. You're going to, chase more rabbit holes and patch in more knowledge. But later on, you have to recognize you can't run down every rabbit hole. You are looking for the biggest takeaways. And so I'll talk a little bit more about this in how to review, but essentially, as you get more towards the later portion here, and let's say you did those 120 questions and you got 50% of those correct, you might be feeling discouraged. Shoot, that's 60 correct, 60 incorrects. Oh my gosh, that's half the stuff I don't know. Stop that thought right there. Are you trying to get all of these 120 questions correct in the first place? No. You're trying to get 70% of them correct. That's where you need to be. So, one of the concepts that I talk about in the Fuller book of Aim High, Score Higher is find your 28. Every block of 40, you only need to get 28 of those right. Find your 28. Your best systems, your best knowledge, that's going to be getting you to where you know enough. So going back to that practice day where you've done 120, you got 60 right and 60 wrong, instead of thinking I need to go through those other 60 and know all of the stuff about all of those, think, how could I have gotten from this 50% I was at to the 70% I want to be at most easily? That means out of those 60 I missed, I only needed to get 20%, not the 50%. So I only needed to get 2/5 of those, meaning I'm just mathing on the fly here. 24 of those 60 is what I actually need to get correct. Where are the easiest 24 out of those 60 for you to get right next time? Logan, is that making sense? I just want to do a quick vibe check with you guys on this.
Yeah, no, I think that's great. I think I'm in the rabbit hole stage for sure, but I think I really like that idea of, finding the easy ones to get to that 70% threshold. So no, I think that's super helpful.
Yeah, that mind shift alone, I think also really helps with getting discouraged by low percent corrects. The thing I try and remind students of as well, again, is with that standardized exam, you're not trying to get 100. You're not trying to get a 90. You're not trying to get an 80. You're trying to get a 70% at the end of the day, which means as you're prepping and practicing these skills, it is completely normal to get scores in the 30s, 40s, 50s, and 60s on your way up to getting a consistent 70. So just normalizing that as this is how I am preparing and building this skill set versus I've gone and done the studying. I'm supposed to be able to come take these questions and get a 70 now. It's not a direct translation. So be comfortable with the fact of, okay, I've studied this content enough. I understand this well enough that it really comes down to more about my ability to apply it. And I just need to practice this process more. Versus if you're doing these questions and you've got no idea what the differential could be, or you are looking at the answer choices and none of them make any sense to you, okay, that's some targeted topic review. Versus, see how far you followed this process. Because a lot of times students will be getting discouraged near the end and then I actually work through it with them and they're like, well, it's this disease. I can tell this is what's going on. This means this. And oh, I don't know that last thing that they're wanting me to figure out here. Maybe it's this. Oh, dang, I missed it. And they're treating that miss the same as months prior when they looked at that and were like, yeah, I have no idea. See? Those are completely different misses. So, as you're going through and reviewing, I want you to really think about where you would have been previously when you got this wrong. The other thing I love to remind students of, you're gonna have to keep revisiting subjects, guys. That is normal. And that's just how it is, which is why you don't want to just slowly deep dive every subject, because by the time you get through them, you're going to have forgotten the stuff from the earlier ones. You gotta be willing to just buckle in and get through stuff and get down what you can get, and then patch in more holes the next pass. But the other thing I want you to think about here is not where did I leave off from cardio last time? I had just deep dived and I was like at my peak cardio, and now it's been 2 months and I'm mad at myself because my cardio right now isn't as good as when I had left it before. Like, does that make sense logically? Like, we're just being hard on ourselves. So instead, what I want you to think about, compare yourself to when you came to cardio last time. When I started studying cardio last time, I didn't know what any of this stuff even meant. I may not remember as much as when I finished that study block, but coming back to it right now, holy cow, I know so much more than when I started studying cardio last time. And if you can make that frame shift with your mind as well, that will really help with that burnout and discouragement. You are improving, guys. Look at it in terms of last time I came to cardio, not where I left it. Last time I came to biochemistry and it seemed like a foreign language. And now I'm just mixing up, different congenital disorders here, but I almost had it. Big differences. So keep that in mind and that you are progressing through that way as well. I'll go ahead and pause here for any questions, comments. Yeah, and we'll talk about, I see in the chat there about getting discouraged with how long the review time takes. Let's go ahead and run poll 6, AP. I'm curious how you guys feel about the endurance aspect here. All right, that's good, AP. So we're gonna run a couple of these a little quicker here. So how you guys feel about completing the timed blocks? We've got the I avoid timed mode and stay in tutor mode. Very common and totally fine earlier on as well. I'm a big fan of you do it the right way and then you do it the right way more efficiently. If you go into timed mode too early, you end up developing just poor heuristics of whatever gets you to an answer the quickest right now. And so, what I'll be talking about in the next portion is my 5P approach to each clinical vignette and how to treat it the same way every time, a line at a time, and then getting more efficient and more effective at doing that versus just trying to read answer choices or, the labs and just get to an answer as quick as you can. All right, getting through one timed block was okay, but more is rough. And then, yeah, there was a 120 test that they had to do. So 120 felt manageable for one person, but the full is unfathomable, is what I put. Because, yeah, full day is 40 blocks, or not 40 blocks. Whew, that would be really bad. 7 blocks of 40 done over 8 hours. It is a grueling day of just the mental endurance. But like a marathon runner, it's something you've got to work up towards. Don't feel bad about that yet. It's just something you want to scale as you progress. And so let's say you're spending like 20% of your time right now doing questions and 80% of your time reviewing content. You just want to make sure you keep shifting that every week to 2 weeks to where you'll be doing 40% questions and 60% content, and then 60% questions, 40% content. And then by the time you're getting close to test day, you should be doing practice questions like 80% of your time. And then just doing that larger scale review, looking for the lower hanging review fruit and doing that targeted topic review. All right, let's pull up number 7. What up, Izzy?
Morning, Izzy.
Hey everyone.
Right, we are just launching poll 7, our test readiness check. What would make you guys feel like you were most ready to sit for step 1? It says most ready, but this one is multi-select if you feel a couple of these are fitting for you. I personally threw in the last one just because that's a major determiner for myself. AP, can you walk us through what you are seeing here, my friend?
I see us having to pass multiple of them consistently, which I think is going to be a good sign. Being able to pass pass the NVMe free 120 with a buffer, okay.
Mhm,
Let's
mhm.
see, few repeated errors above in my error log, feeling calm with timing and skip rules, feeling I would approach every question. Okay. I think especially that one, whoever responded to that one, it's very good because again, as you know, Dr. Deason just elaborated, there are going to be various levels of difficulty of these questions, right? There will be some that are really ridiculously easy, and there will be some that are ridiculously hard. You don't want to sit there and spend 2 whole minutes looking at a question. That you don't want to do, right? It has to be at some point where you look at a question and be like, okay, I don't know this, make an educated guess and move on, right? And because you want to make sure you get all these done in time. So that's a good response. Anything you want to add to there, Disa?
I would expect the first two from everyone that, we all want to see the practice exams where they need to be. That's the main confidence booster. Like, hey, I just did this test and it says I have a 99% chance of passing. Cool. That makes me feel confident. Um, I agree. You do not need to actually be able to simulate a full test day without crashing. I was curious if anyone would pick that, but notice the full length practice exams, or I shouldn't call them full lengths because they aren't. The practice exams that are put out are not full lengths. They are all like 120, 160 in that range, and that's okay. That's enough. If you can do it through 4 blocks, you can do it through 7. And the idea here, if I want to throw back to the marathon runner analogy, marathon runners aren't out running 26 miles frequently before they go and run the marathon. You will burn yourself out trying to do 280 days. It's not needed. UWorld percent correct above the threshold. I see, some students do get fixated on that. They want to see their percent correct on UWorld to be like at that 65 or 70. But I discourage using that as an anchoring point because UWorld is there for your practice-based learning. You should be using it to improve towards that 70%. So it is totally fine to be going in there, getting your 40s and 50s and seeing where to patch things up rather than freaking out that the UWorld percent correct needs to be at a certain level. As long as you're maximizing your learning from every quiz, that is way more important than what you score on that quiz. I just want to say that one more time. It is more important that you are learning the most you can from each quiz you take than what you score on that quiz. So don't worry if the score is low. And students are way more apt to get discouraged by low scores closer to test day. But remember, these aren't full length exams. These aren't predetermined blocks set to that standardized scale. You're at this point pulling together random quizzes of random questions. There's going to be way more variability in that. So instead, use any lower scores that pop up as opportunities to learn. And if you shift that mindset to being like, I know I'm going to get my 70% on the day of, until then, let's see which ones can get me the most. Which random batches of questions can hit me to a lower percent, and which ones can I do better on? And just take it as data and adapt and pivot rather than feeling like you got beaten down or beat up by it. All right, I'm gonna go ahead and we can kick off our first little just break of the day here. Make sure everyone gets a few minutes to grab coffee, use the restroom, and then when we come back, we'll do our first prize giveaway of the day. So thank you guys who have been with us so far, and I will see you back in 5. All right, we'll be kicking it back off here in 1 minute. All right. Give me one in the chat if you are back. Wow, that was a long, sleepy sigh, Nessa. Sheesh. All right, let's go ahead for our first prize giveaway of the day. It is going to be 1 year's access to the DDQX Learning Trivia, but I have decided that we are going to be giving that prize to each of our attendees today. So, Logan, Rima, Ryan, Izzy, you guys are all gonna have the subscriber role added in the DDQX Learning Discord. So let me know just in a DM. I'll make sure I know what your Discord name is so I don't mess it up. And I can flip on that subscriber role for you for a year so you can get in there, answer those trivia questions, have some fun with it, and learn some stuff at the same time. Right, let's go ahead and kick off the next part with poll 8.
Alrighty. Let us see here. Do.
Strategy check. What is your usual first move when you open a clinical vignette? All right, so we have one response for reading the last line first to find the task. Two folks picking skim for key info in the question, then read deeper. And one for start at the beginning and treat it like a patient. I'm gonna just take a wild stab that Izzy picked that one.
Yeah, that was me. If you asked me months ago, I would have probably picked the one where it said read the last sentence first. That was my old approach.
What changed, Izzy?
Working with you, probably the main thing. Surprise, surprise. And then also I think just like we've talked about it, since I'm very kinesthetic in the way that I learn, like kind of tricking myself into these being like me walking in and pretending I'm seeing these patients has really helped like create the story just more authentically in my brain. So then it makes me think more and not just panic.
Yeah. Yeah, I think that's one thing that we had seen across our time together is you now feel like you can approach any question, correct?
Yeah, exactly. Like I feel like they can throw anything and I'll use the same like systematic way.
Yeah, awesome. So you already know what that way is. I'm gonna go ahead and pull up a case here to show our other friends who have joined us today what I am talking about when I say to think like a physician and to treat your questions like patients now so you don't try treating your patients like their questions later, because that isn't going to work out too well for you either. So I'm going to pull up here an example of one of my cardiac cases. Actually, I take that back, guys. It is a chest pain case because I don't organize by subject or system. I organize by chief complaint. And so this is still adaptable if you use one of the other methods. You can still look at the question first or, do a quicker skim. But essentially, let me go ahead. I got to share my screen that shows the case. That would help. Of course, I'm going to hit slideshow and watch. It's going to be the wrong one. Got to switch it. There we go. All right. So this is what I want you guys to do on all the other cases. I only make like 10 cases per chief complaint and show them with decks because it takes a lot of freaking time, and UWorld already wrote 3,700 other cases that you guys are going to answer. So I'm like, hey, here's like, 50 examples I've made. You can use that on the other 3,700 now. So that's my approach to making content for this. But before we get into the case, let's just talk about chest pain. This is what you guys should be thinking right off the bat. Is cardiac or not cardiac? Logan, if I said I've got a 74-year-old male with hypertension and hyperlipidemia in bed 3 for you with chest pain, and in bed 4, I've got a 28-year-old female with a history of anxiety complaining of chest pain. Are you walking over to those two beds with the same differentials in mind?
No,
Absolutely not. And are you going to be asking those folks the same questions?
no,
Doing the same exam maneuvers? Ordering the same labs and imaging? Nope, 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 nope. So let's start at the very beginning of, does it feel cardiac or not cardiac? Because that's going to be what shapes your differential, which is going to shape your questioning, which is going to shape your physical exam maneuvers that you do, and the labs and imaging. And again, you're following a story. So, is the question that's in front of you a cardiac story, or is it not a cardiac story? That's where you should really start off. You guys are familiar with Vindicate, which honestly puts you ahead of a lot of other folks out there, and I've heard it's expanded beyond Vindicate. Not getting into that today. I learned Vindicate. I thought it was enough letters. But, when we're talking about chest pain, it does help, to be thinking like, is this a vascular issue, an infectious issue, neoplastic, degenerative, or drugs? Iatrogenic, which for those who don't know is the fancy medical term for we did it, like physician induced. Oops, but we're gonna say iatrogenically caused in front of patients, so we're on the hush hush. Congenital, not gonna see that in too many older folks, but your younger ones, you're always gonna want to consider that. Your autoimmune, allergic, anatomic, traumatic, endocrine environment. A lot of different sources that issues could come from. So don't pigeonhole yourself too early into thinking of one source. Your initial approach, this is good old paramedic Brandon, EMT Brandon, who got hammered into him A, B, C, D, E. And as I went into my EM residency, same thing. This is how you handle stuff in the ED. Always, the most important thing is if their airway's patent and protected. Because if it's not, you need to fix that first. Don't worry about everything else. They got to have an airway and they got to be breathing. And their circulation needs to be stable. And all of this, that ABC, you can tell as you're walking up to the patient. Now, certain things like laying my hands on them to feel their pulse and, their skin, what that can help, but I'm already thinking about the ABC while I'm walking up. D, your disability, that is talking about in comparison to their baseline. So, how are they compared to normal? That's the other thing you always got to figure out. Like, oh no, grandpa's always out of it. This is his normal. Okay, cool. Versus like, No, that dude's sharp as a tack normally, and he doesn't know where he's at or what's going on right now. Big difference. And then I always put E on here too for you guys to never forget. You don't want to be the a-hole who's working somebody up as cardiac chest pain and like didn't, cut the shirt off and realize there was a knife wound in their back. So exposure, make sure you see and check for trauma, skin changes, any other clues. And then triage. I know you guys aren't used to having to triage patients at this point in your careers, but I want you to learn to start mentally triaging your patients as you're going through these questions, even as whether this feels like a green patient to you, whether this feels like a yellow patient, a red patient, or somewhere in between two of these. Because that feeling alone will really help you with determining what the most appropriate next step is going to be. Beyond the initial diagnosis, if somebody's green, I'm not doing some super expensive or fancy thing or something really invasive. They can follow up with PCP. I am good to discharge them and not get sued. Different ways you could think of it. Yellow is like, all right, they're here and something's going on, and I need to either figure out a little bit more or make some sort of initial change or treatment. So that's you're less emergent, but I need to do something right now. So a CT is a reasonable next step. Making a medication change, starting a medication to treat something. Cool. Those are all yellow patients, yellow answers. Red is same as in real life. Like imagine if I walked away from this patient, they could die and like I would be responsible for that. There's certain patient rooms that you will walk into and realize you happen to stroll in there first as the medical student and oh crap, this is like a red patient and I need to be getting everybody else, not sitting here doing an interview for the next 20 minutes and then strolling out and going, I think he might be having a heart attack. I did this full question set and physical exam, and yeah, he was like pale and started throwing up and super sweaty the whole time. Kind of got on me. It was gross. No, that wouldn't be the good place to be. So start thinking that way now, and then the answer choices make a lot more sense in that context too. This person's red. I don't actually have time to do a CT. This will make more sense on rotations, but CTs take like 40 minutes. That's not something you can wait for when somebody's red. You can do a fast ultrasound. You can do like an X-ray if they're in the trauma bay, or you've got a portable right there. But otherwise, it's like exploratory laparotomy, intubate. These are the times we can do the more serious interventions right now as the next step. All right, so that's going to be even more important as you get into step 2CK because so many more of the questions will switch to the next best step. But start training your brain this way now of does this person feel green, yellow, red, somewhere in between. All right, guys, this is my freaking bread and butter right here, my 5P approach. I normally don't teach this to anyone outside of my one-on-one coaching. This is how I teach students for 4 years now to approach every single medical case and have seen vast improvements and turnarounds for all of them. I give this to you today as just something to incorporate and start doing every time. When you start your question and you're going through, you're trying to prioritize the key information as well as just notice what is being prioritized to you. Going back to that idea of you're being told a story in 1 minute. What's being prioritized to you? I learned this the hard way as a question writer. I don't get to include that this person's Hispanic or non-binary or homosexual or whatever, just because I wanted to write more diverse, realistic questions. I was applauded for that thought and effort, and then told to go back and look at the USMLE questions, the NBME questions from which I was making test-like products, and if they did that. And then I went and looked and I said, no, they only do it when it has to do with the diagnosis. And they said, that's right, Brandon. So only write questions, only tell us the occupation or the ethnicity or some other life fact about them if it fits into the story, if it affects the differential. That's the other thing to keep in mind. That last sentence I said there, if it affects the differential. A sentence can be there that doesn't have to do with that diagnosis if it's telling you something else about your differential. Very common example I give for this one is, hey, this person's drinking a lot and they're peeing a lot. We're thinking, okay, that's something diabetes related. The only time I ever write this sentence, blood glucose is normal. I don't even bother giving a value. I'm like, they're drinking a lot, they're peeing a lot, blood glucose is normal. What am I trying to tell you, Logan? And thank you for participating. I see you on
Yeah.
camera, and it just is an easy go-to.
No, you're totally good. That it may or may not be related to diabetes in that case.
So in this case, I'm like, hey, these are diabetes symptoms, but there's diabetes mellitus, which is blood sugar, and there's diabetes insipidus, which is like our ADH and
Yeah.
stuff like that. So the only time I'm like, hey, this is like diabetes symptoms, but blood sugar, totally fine. That is just my like one-liner for you to pivot to insipidus.
Insipidus. Gotcha.
Yep. So every sentence is there for a reason. That's one thing I like to emphasize. Izzy, how many times have I told you to go back and re-highlight over like a sentence that you blew through?
A lot.
Everyone is there for a reason. There's not fluff. Granted, guys, I will say this right now. UWorld and other resources don't follow this perfectly. I'm telling you what your NBME questions will be doing. Everything else is a paid for resource where they paid people like me to do a best effort to make them questions. Doesn't mean everybody fully understood the rules of how to do that or did it appropriately every time. So you will see questions out there with red herrings and shit that trick you, and you'll be like, what the heck? My biggest takeaway for you from those is to just go, that's not test like, but what are some like interesting facts that this brought up that I could take away for next time? Okay. So as after you've gotten through your question and you have your sort of triage in mind, so many of your questions will be phrased with what's the most, likely diagnosis in this patient? What's the most appropriate next step for this patient? Easiest way to do the paraphrase step here is to replace the words this patient with your summary of that patient. What's the most likely diagnosis in this 64-year-old with hyperlipidemia and hypertension who presented with crushing chest pain, after activity and it resolved with rest? Oh, okay, cool. This is a stable angina guy. Next thing is this. So that's your opportunity to paraphrase. Prognose. This is my, medicalese for like predict what you think the correct answer should say before you're looking at the answer choices. You should be thinking clinically along a differential as you're going through this. And by the time you've read that question, I want you to try and have a general framework of what you think the correct answer should say. My, generic term, the correct answer should say X. The reason I stress this is for this pick step. This, like 1, 2, and 3, my method is slower than if you just blew through reading the whole question. Hands down. Acknowledge that because you're going to save time here with the answer choices. Because instead of evaluating every one of these choices and what you think about it, you're going to say, does A say X? Yes or no? Does B? Does C? Does D? Does E? Look for the one that matches what you already were predicting. If you're not seeing a match to your first prediction, then whatever was second most likely in your mind, your why, you could say, go take a look for that. And if neither of those were there, you really just missed what the heck was going on this one. Take your best guess and move on. You only have 90 seconds per question here. No one question is worth not getting to several questions later. Whether you get it right or wrong, it is never worth 3, 4, 5 minutes of your time on one question unless you have gone through the full set and you've just got time to spare. Okay. And then for the review part, we'll get more into this. The fifth P is just for the review portion, not for answering, but I call it the post-mortem because I really wanted to emphasize, in medicine, if we did our best and treated someone and they passed away on us, we perform a post-mortem. And, sometimes we'll have morbidity and mortality conferences. Are we talking about how to help that patient next time? Logan, I see you got a hand up.
Yeah, I was curious with the 5P approach.
Hmm.
So I was the one who put that I read the like last line, the
Yeah.
question stem, and then go back in. So I really like the idea of having one system for every question. I think
Hmm.
that's definitely been resonating. I'm curious how you like uh the argument for having a system like this,
Mm.
where like, the annoying questions where they give you a whole long vignette and then you see the question right before they're like, this patient was given doxycycline. What
Right.
congenital impacts will this have on the infant? So they tell you
Mm.
everything you need at the very end and all the
Yeah.
stuff before is almost irrelevant. Like, I guess, what's the reasoning why we should do this approach as opposed to like the other approach?
I am so happy you asked that, Logan. So, I will acknowledge, first off, that you are absolutely correct. There is a subset of questions where the case or the prior information is essentially irrelevant pretext to answering the question at hand. The next thing I'll say is there is much less of that on step 2 CK than there is on step 1. And then the other thing is recognizing general patterns of when I've started a question that is like that. I pick up and will skim it and be like, all right, you're talking about, oh, a medical student has come in for a study. Then I'm like, okay, normal, 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 normal. What's the exercise physiology change? Cool. So if I'm seeing that the information being prioritized to me seems like pretext, I'll just kind of speed up and move through it and get to the question.
Cool.
I would say, you'll lose some time perhaps using my method on these questions, but you'll save time elsewhere from reading the answer or the question every single time versus just starting with the case and moving through it.
Cool. Yeah, that makes sense. It sounds like it's more about like the pattern recognition side of it then. And
Mhm.
even playing into that, then you can recognize the patterns of questions where it probably will throw something like a pathophys at you with the answer. So that makes sense.
Or if I see a question that has, like a cadaver with A, B, C, D, E on it on structures, I'm like, oh, this is going to just be like an anatomy question. And my case is about somebody who died so we could do an autopsy. So there's other things like that. that where, yeah, if you can tell like from some pattern recognition over time, this will be just like pretext, then I just, pick up my speed here and I'm like, okay, you're just giving me the pretext for asking about this guy who died. Cool. All right. So show you a quick example. It's never about the answer choices right off the bat. And when you're going through, I break these roughly into these categories. And now this isn't, I'm going to change this one of these days because it's not the same as like risk factors like we use in medicine, but more just what's getting prioritized up here as being like most relevant to your differential. And then from that, we will move into current presentation and then pertinent history, initial findings, any additional info. This is again coming from somebody who wrote and edited 15,000 questions of this style while I was at Kaplan. This is the structure that is used by NBME. This is what we are supposed to replicate as content creators. So as you go through, you're essentially what's most important is like, all right, this is a 42-year-old guy who was brought in after an MVC, mild chest tenderness, right leg pain. Okay. What else you got for me? His unrestrained driver struck an electric pole. So I look for anything about mechanism. Were they T-boned? Was it a head-on? Whatever else I can get. Were they buckled? Not buckled? All right. Then initial findings is usually when the vitals start. So we look for any aberrancies there. Whatever other descriptors we get of the physical exam. Mild ecchymosis, anterior chest wall. Ooh, okay, that's always a good sign for maybe like, pericardial effusion or cardiac tamponade kind of thing. Let's see what we get else. Okay, ecchymosis, large lump midway up the right thigh, overlying skin intact. All right, so that is a bad fracture there. If we've got a big lump, cool. And skin intact means we're not breaking through and getting like infection from outside sources. So I'm not as concerned about that. Then they're like, hey, we, reduced it, immobilized it, sent him home. Whenever you get any sort of part of the story is they were seen the first time and then they come back, it has to do with something that happened the first time. Only time I write those. Again, this is a 60-second story. And you get like, if you think about it that way, I know some people are like 30 seconds on that and a minute thinking about it, but I usually am like a minute thinking about it and 30 seconds answering it. As I'm going through this story, something happened, then they come back. That is what I'm looking for. All right. He's coming back 2 days later, chest pain on inspiration, shortness of breath, differences in vitals, differences in findings. What's the most likely cause? Okay, cool. This is the setup. You're really asking me the most likely cause of chest pain in this 42-year-old male who's 2 days status post MVC, where, I would have added probably two with the reduced fracture. And he's now presenting with pleuritic chest pain, dyspnea, new onset hypotension, hypoxia, and probable DVT. I'll show you guys the differential. And then I encourage you to think about like what supports and detracts from the different items of these differentials. So as you're working through your case, again, at the beginning, I'm like, cardiac or not cardiac? Well, all right, here's a lot of story, and then they're coming back. Well, this coming back chest pain, this seems not cardiac to me directly, Inspiration, shortness of breath. All right, so seems related to this leg. I'm going to think about the things that would be related to the leg, which is probably more along the lines of the emboli over something that would have been an acute injury like tension pneumo or the cardiac tamponade or an aortic dissection. So already right there, you can be like more likely this and this, less likely these things, given that he's coming back 2 days later and it's not right after the MVC. Cool. These are the kind of questions I would be wanting to ask myself. What's going to be immediate post MVC versus presenting later? And in this case, again, this was also presenting after the reduction of an open fracture. And pleuritic chest pain, what could be coming with that? And what would differentiate our thromboembolism from a fat emboli? So then you're like, all right, this is what I'm thinking about. The timing gets ruled out, rules out our dissection or tamponade. Our normal cardiac is going to rule out the pneumothorax. A DVT is likely going to be thrombic over the fat emboli. Fat emboli, we are tempted here because of, this fracture with the thigh, but that fat emboli gets displaced either at the time of the break or the time of the reduction. So that's something to keep an eye out for versus this person's been sitting home, it's been reduced, but they've been relatively immobile. They've got a new onset DVT. That's more likely a thromboembolism. So this is where, follow the story, see what they're presenting. Why would I tell you about new erythema and swelling in the right leg distal to the fracture site if I was focusing on a fat emboli? That's not the story that you're being presented with. And that's how, even when you're not sure of how all the breadcrumbs line up, I talk about just the fact you're following a trail. You might not recognize every crumb along that trail or know exactly where it's going, but you can still follow the general direction to end up in the relatively right area and using that to follow through on what's closest. All right, now the post-mortem. So when you are finished with your question set and you're looking back on the questions, it is not really that important of how do I get this question correct next time. That is the reason I call it the post-mortem. That question is dead. You have killed it. You are not coming back to that exact question again. You are not being presented with that exact case again in the future. So instead of just thinking about why is this correct here and why are these other things incorrect, you should always be thinking about preparing for next time. And how many future cases and questions can you prepare for off of this one? And I break that into 3 topics or 3 categories here. If I was given this same exact case over again as the pretext, what other questions could I have been asked? This one doesn't have them filled in. So some of them I filled in, but most of the time I leave that up to you guys because I'm like, ugh, that's just me doing the work. But, what are some other things like with this guy's case that they could ask us about? Well, beyond the diagnosis, it could ask about mechanism. It can ask about next step in treatment. It can talk about how we would ultimately treat the guy, or, I should say next step in management versus the ultimate treatment, versus sometimes like what would we need to do to be able to discharge this person safely. So various aspects like that. Second category is thinking about the next person who comes in with this diagnosis. So, this person just had a thromboembolism. What's the next thromboembolism case going to potentially look like versus this one? And going, okay, the other ones I'm going to want to look out for are, my women on OCPs or other hypercoagulable states, immobilizations, and just keeping that in mind. And I'm usually going to see something like a DVT as a predisposing factor. Cool. And then the third one is how would you minimally change the case to arrive at one of the other diagnoses? That is how you can really tell things apart. This test is what differentiates between these two things. This finding is what really made it more this instead of that. And if I changed it and instead said, hey, there was no DVT, hey, this was like shortly after his leg was reduced, he had new onset chest pain, pleuritic chest pain. That would be my fat embolism. And if you can walk yourself mentally through how would the case look different, like minimally to instead get at something else here? Hey, if he had hit that steering wheel and then they had focused on Beck's triad, that would be my cardiac tamponade case. That is how you're gonna best prepare yourself for the future. I saw some good nods there. You like what you're hearing, Logan?
Yeah, no, I think that makes sense. I think that's one thing I struggle with after, like during my reviews, is knowing that, well, it's great that I know how to answer this question, but it stinks that I probably will never see this exact question again. So figuring out like how can I still learn from it and apply it to future questions? And I think that this is a good strategy to do that because it tackles all of the answer choices and not just knowing what the answer choices are, but knowing like how you can change the question to get that answer choice. So when that comes up in the future, you'll be ready for it.
Perfect. Great recap there. Thank you. So yeah, that's really, Izzy's been working with me on this for the past few months. What would you say, Izzy, has changed for you in terms of like how you approach reviewing questions?
Mm, yeah, like I agree with Logan that I feel like it's hard to have that skill of like reviewing it because I would kind of same thing as like, oh, okay, I knew it in this one moment, in this one context, but I'd even like look at the question, and I feel like one thing I've gotten better at is looking at the evidence that was given in the question that even pointed me towards the answer or pointed me away from the other ones. Like the other day, I was doing a question, and it was like a um, mother who had given birth like a couple weeks ago, and she was having hyperthyroid symptoms. And at first, I was like, "Ooh, it could be the Sheehan or something." But then I thought, okay, no, she's breastfeeding normally, so that would pull me away from answer C. So like things like that, where you start to piece together what things are pointing you to or against. It's become a better skill.
Awesome. And I know one thing that you and I have also worked on a lot is just things like using the nomenclature of the answer choices as the takeaway sometimes of like, oh, I couldn't really tell these different tumor answer choices apart. And I would press you on like, well, what does the sarcoma part mean versus the carcinoma? And how does that relate to this case? And so when we would dive into things like tumor nomenclature and understanding that as a takeaway to be able to better answer future questions or to at least be able to make an educated guess on them. And I know we did an optho question the same kind of way, where it was like, oh, what muscle's the problem for somebody whose left eye can't look past the midline over to the right? And we were like, well, it's not going to be on the right side. We got rid of those three answer choices, and then we had three on the left side. And then two of them were like abducens, things. And I was like, well, if we're abducting, we're taking away. So that would be
Mhm.
looking to the outside versus the last one was a medial. And it was like, well, if we pull on the inside of the eye, that lets us look right. So it's got to be the left medial thing.
Yeah.
And that's how, I don't have all those memorized offhand, guys, like their exact courses anymore and what they do, but I can be like left side, and if it's on the medial, that's what pulls to make me look to the right. Cool. And that's what I
Yeah.
love showing you that too, with questions where I'm like, how could I show you how to answer this with like minimal memorized things and how I'm like, it probably means that.
Yeah. I feel like the logic, like, I guess, yeah, implementing more logic. Sometimes the questions are as straightforward as you would think. And and they look scary and they're really long, but like, yeah, that just keeping straight, well, they gave me this evidence. This is what makes most sense. Like, I think we're just kind of conditioned to doubt ourselves all the time, but at least I am. Um, but then you like piece together, like, no, that is the scenario they're giving me.
Yeah. One thing, if you don't mind commenting on as well, is since we talked about it recently, is how do you go from one system to realizing something's multi-system?
Ooh, yeah. Let's see. Um, I guess so. You've kind of taught me like in the first sentence. So I'll read one that's up. It says a 72-year-old man is brought to the office because of a 6-month history of increasing fatigue and 1 month history of numbness of his feet. So if it was just left at fatigue, I could think like, okay, it's like maybe some sort of blood loss,
Mm,
nutritional deficiency, things like that. But then it ties in, at least for me, it wasn't just
mm,
like a heme issue specifically. Now I'm seeing signs of like neurological deficits. So like proprioception and sensation of vibration are decreased.
mm,
So like you've like kind of that first sentence, if it isolates it to just like cardiac or pulmonary, then that's the main organ system to keep in mind. But then usually the following couple sentences will tie in other organ systems.
yeah. So I would say, the key is like after that first sentence, see if you can kind of hone in on your favorite part of Vindicate or system, for that issue. I know we had that case with the kiddo where it was like first sentence was like, "Oh, they're bringing in this kid that presents with a rash." And I was like, "Okay, a skin problem." And then the second sentence was like, "This kid has had like muscle problems and, pains and weaknesses." And I was like, "Oh, a muscle problem." And then, you were going to keep reading, and I was like, "Hey, hang on, before we keep reading, what has skin and muscle problems?" And you're like, "Oh, yeah, maybe dermatomyositis."
Yeah, and I didn't catch that the first time I did the question, but when you paused and said it, like what involves the two, I was like, oh yeah, I remember that was tested.
Yeah, yeah, there's that disease that's like skin and muscle disease. Like, got it. So just giving yourself that chance to pause a little after every sentence and reflect on where you were going with it. And, sarcoidosis, guys, is another really common one where who knows which thing they'll throw at you first as the presenting symptom. They're coming in because of these painful nodules on their shin. Oh, and then on chest x-ray, we're seeing all of these other, random findings of stuff. And then, oh, we're realizing one of their eyes has blurry vision. Or I could randomize that order, or I could present with the cardiac instead. But the thing here is you're like, nodules on the shins don't really have to do with the lungs normally. You mean, eh? And then an eye thing, what the hell? That is a way different system. So that's where you start going, okay, this is a multi-system disease disorder. Now let me shift my mind to what brings these ones together. And some of my favorite ways of going about that is anchoring from like a favorite system of mine. So, I really liked Pathoma's renal chapter, and I got down understanding everything from the renal perspective. And so then I treated the multi systems that involved renal as renal and. So it was what is renal and lung? Oh, that's going to be good pasture. What's renal and eye or ear problems in this kiddo? Oh, that's Alport syndrome. Super easy, obvious to me at that point because I had the anchoring. I knew my renal differentials and my renal multi-system differentials, and then I could go from there. So finding the differentials that make the most sense to you and looking for the ways that certain things are grouped together because you can approach questions from multiple directions sometimes. For me, another one was just like skin change disorders. Like there's only so like that's not something that's really like grouped together too often, but it's like there's only so many things that change the color of the skin. It's either like an iron problem or a glucose problem. So as soon as they're saying like blah 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 and skin changes, I was like, "Oh, well that's easy. This has not been talking about glucose the whole time. It's been talking about iron stuff." So I'm gonna be going towards Addison's disease here. And, that's just being able to look at different ways you could kind of group things together to tell them apart can be another good exercise in terms of locking into what's most likely in a given case. Okay, I'll go ahead and pause there. That's really, the gist of the 5P approach. And again, just trying to systematically apply that every time. You will have some, Logan, where you start reading it and start analyzing and coming up with the diagnosis, and then they're like, this person has this disease. And you're like, okay, but it's still really reinforcing. It feels so freaking good when you're like, okay, this is going to be a person with this. And then they're like, oh, and we diagnosed him with this. And you're like, damn right you did. So that's how I treat it. It's not wasted effort because you're there already, not only on the trail, but knowing what breadcrumb is coming next. And when they verify it for you, you're just like, yes, I am on this trail. Great. So don't feel like it's wasted effort to be following the clinical reasoning and then, hey, here's the diagnosis. And you're like, well, I didn't have to come to that on my own. But you did, and it all makes sense to you, and you should know where they're going to be going next with this because you've been following it the whole time. All right. Any questions, comments, concerns on the 5Ps? Sweet. We will take 5-minute break number 2. Come back with another prize giveaway that I will make up in the next 5 minutes. Haha. Just keeping it real, guys. There was only so much pre-planning. Great question, Rena. How long should it take to review questions using the 5Ps? This is something that I would say you will get more efficient with over time. The first 4Ps are still really more about answering, how you move through and answer the case, whereas really just the post-mortem is about the review. And I would say the post-mortem does need to be done somewhat sparingly early on. You're not too efficient with it yet, and you can't rabbit hole everything. But recognizing when you're dealing with a major differential, like I really should be able to tell apart stable angina from unstable angina, from STEMI, from end-STEMI. I know, and from vasospastic angina. I know these are going to get tested relentlessly. This is a great thing to really post-mortem and go, what exactly changes it from stable to unstable? What changes it from the STEMI to the end STEMI or vice versa? When am I going to see vasospastic? A 30-year-old dude who is working a lot, coming in with chest pain and is jittery, is your cocaine user of vasospastic angina. Like, being able to just tell those stories apart and making sure you're comfortable with that is how you make sure, like, cool, that differential I feel good on. And then trying to build out the differentials that you're comfortable with, going from higher yield stuff to lower yield stuff. Absolutely. And like I wish I could give a little more specifics, but again, there's no one size fits all answer here. But recognizing like these are the things that, especially as you get a little further in and you're getting done 20, 30, 40 questions and then reviewing, I don't want you to deep dive every question. I want you to treat each of these opportunities as instead, how would I close the gap? I got a 50 on this and I want a 70. Even, 10 questions. Where's the other two out of the five I missed that would have been easiest to get? Postmortem those. The other ones, all right, was this nice to know stuff? Really hard stuff? Cool. Make a mental note. That might be a useful table. See if it comes up more often again in the future. And then as you're doing more, if you see they keep bringing up this table that tells like these things apart, that is a good like post-mortem deep dive to prepare for as many future questions as possible. So that's where I would say, use the post-mortem. It will probably take you, I mean, you could be spending like 5, 10, 15 minutes initially, on post-morteming one question. Um, and that's okay if you're getting, again, what you need to out of that. And that's all like high yield, super important differential. The other way, I know, Izzy, you've been trying this out lately, is when you're post-morteming, you're doing it with Chat GPT.
Yeah.
You
Yeah, I
want to talk
feel.
a little bit about like how you're using that?
Yeah. Let's see. Trying to pull up. Basically, so I'll go in there and
Oh, I
in
said we were
general,
starting a break and then I got super
I
excited about this.
sorry.
Sorry, guys.
Uh, uh so basically I'll just like yesterday I looked at a question and it was like on chemo drugs and I wasn't even sure like if I was interpreting what they were asking me correctly. So like one, I'll have it check like, hey, this I said, is this question wanting me to identify the underlying pathophysiology of the adverse effects? Because they're asking me why new therapy was then added after they gave that chemo drug. So then it kind of confirms, like, yes, that's what they're trying to get you to like go towards. Um, so I'll use it for that, like question interpretation, but then I'll also ask it or tell it, this was my thought process in picking this. And then I'll ask it to identify like any gaps in my thought process or just have it confirm or things like that. So more like a dialogue, not just like a
Yeah,
why is A the right answer?
right. Yeah. And again, I would recommend even thinking about like asking it, how could this be presented in the future? Or like what other ways could I be tested on this? As some prompts that you could use there. All right, let's go ahead and we'll take our next 5-minute break. When we come back, we will do another prize giveaway, do a couple more polls real quick, and then I'm going to talk a little bit more about the mindset, the daily habits that will lead you to success, and a little bit more of a deep dive on how you can use AI to supplement your learning through this process. So thank you all again for joining us so far, and I'm looking forward to picking back up in a few more minutes. Don't get startled, AP. I'm back.
Haha, very funny. Yeah, fam. I can sometimes get lost in thought on Zoom, so when someone like starts speaking, I literally just like have a jump scare moment. I didn't intend to, but like my body's just pre-programmed to have that. And you think after spending, almost 6 years on Zoom, because I was one of the pandemic children that when my junior year of college began back in March 2020, that's when COVID came around. You'd think I'd get used to it, but alas, I did not. Whoops.
Yeah, I was working virtually for 4 years already when COVID came around. And then I realized shortly after COVID started that most people described my life as quarantine.
Ah,
So when they
well,
were like,
okay.
stay in your home, don't go out except for absolutely essential things like grocery shopping. Don't get into groups of more than like 3 or 4 people at a time. I was like, check, check, check.
I mean, I already fit that profile pretty well even before quarantine began. So it's like, oh well, this is just a normal Tuesday for me. Like, no one gives a shit.
Yeah, yeah. No, so that was one when they were like, people are really struggling mentally with this. I'm like, it's so
Meh.
nice.
Meh.
Like, you mean you like going and interacting with like hundreds of people a day? Weirdos. All right, if you want to pull up poll number 9 for us, AP. And then after that, we will give away our next prize. Review check. So we've been talking about that review process. Just curious what your guys' review process has looked like to date. Okay, we've got our results. One person who likes to focus on the incorrects and marks, somebody who likes to review fast and keep moving on to keep the volume high, and 2 folks who don't have a consistent system yet. Anyone care to elaborate on their response?
Yeah, I don't have a consistent system yet. I feel like for a lot of them, I kind of like go off of the vibes of like, all
Mhm.
right, this one, I try and think back to my thought process and I'm like, all right, where did I go wrong with this? But
Mhm.
then there are times where I'm like, all right, I just need to do some UWorld today, but I don't have the headspace to review. So I'll just do the questions, do a really fast review and call it good.
Hmm.
So, but having a consistent system, I think would really help.
Okay, good to hear. Yeah, one thing I'll be providing all of our attendees today with is a template of an error log that you can use. Izzy, I know you've been implementing that more frequently yourself. It doesn't have to be super complicated. So I have, some templates of error logs that like one of them has like a column for each of the 5 Ps and what you were thinking about as you were going through it. But really, it can just be like, whether you got this question right or wrong, how confident you were on that, and like any other notes you've got. Some people like to tag with subjects and systems and use that tagging as a way to look for patterns over time. I would say, that doesn't need to be done as much now since UWorld and a lot of those have good tagging systems already in place. But, like if you're reviewing NBME exams, um, and want a little bit more detail than, what they present, some of the things that can go help is just, again, looking for the commonalities of what you're missing the most on and not treating it like I have to review even every single question that I missed. I think that can be a good mindset shift. Say that 5 times fast. Is you don't have to do every incorrect and everything marked. That can quickly add up to a whole lot. You get a 40% on a quiz, and you're like, oh, there's 60% of content that I missed, and half the stuff I got right, I'm not even quite sure about. And suddenly you're setting yourself up to try and deep dive 80% of the topics that were covered on that. Versus, again, just saying, like, okay, let's take a look at the ones quickly that I got right and was maybe a little less certain, see if I, ended up following through on some appropriate logic or if it was just a guess. Okay, great. Now let's look at the ones that I missed as a set and see which ones, again, would be the easiest for me to get right next time, or something similar to this to get right next time, and just looking for the set of those that close the gap from where you're at to a 70. So I'll have a student, take a 40 question test and they've gotten like a 65 and they're frustrated and think they need to go study 35% of this content. And it's like, no, you only needed like two more questions out of those 40, bro. So why don't you find like the two that you think like you knew already and messed up on and reinforce that and move on? That is the big difference maker. So just shift it from I have to review everything I'm missing and uncertain on to just what closes the gap for me at any given point and what's enough. How do I get enough knowledge to get through this? All right, let's take a look at. Oh, wait, next giveaway. Ba-ra-pa-pa. So I have decided we will be giving away 1 hour of my time, which is currently valued at $250, according to my website. And that is my coaching time of one-on-one of whatever you need, where I will dive in and create personalized study plan for you of what to do every day. I'll tutor you in a given subject or system. I can help you with a personal statement or planning what specialty you want to go into. Your call. So we have with us here 4 students today. And again, I am just going to say that you all can have 1 hour of my time on the house. So, folks, if you already work with me, you can just add an hour to your established packages. And if you are new, you get 1 hour of my time for whatever you would like. All right, let's go ahead and take a look at poll 10, AP. All right, and so this is again just a little bit of thought of some things you can do as your takeaways. Even if you're doing the post-mortem here, what do you want to actually do from that post-mortem? And again, no one right answer here, and you might be doing multiple of these truly in the given moment. But all right, we can go ahead and end that poll, AP. And actually, I like several of these things. Um, at this point, I don't think you really need to draw any. Oh, wait, let's make sure we are sharing our results here. I don't think you really need to be making any flow charts or, that you're drawing out by hand or writing out any tables on your own unless you're truly a kinesthetic learner. And, sometimes like drawing a pressure volume loop and being like, this point is this point is this point is this point is this. And, that can really help to bring things home, but not something you need to be doing day in, day out. As for tables, usually either UWorld themselves or whatever QBank will provide a table if it's relevant. But If you are seeing some commonalities that you want to deep dive a little bit more, using ChatGPT to help create personalized tables for you of the things that you're struggling with telling apart the most is a great use of that last one. Um, when you are walking away, having a one sentence rule for the miss is really a good takeaway. Try and just, you know, boil that, just like we do with the paraphrase as attendings, right? Like we're taking all of that info and giving a one-liner when we start that off. So do that one-liner for your miss, and that makes you really reinforce what was most important. Anki flashcards are fine, but I tell my students to not make more than 10 to 12 new cards a day, or you'll quickly find yourself in that Anki hole that I mentioned before. Use it sparingly just to reinforce the highest yield stuff. If you start making Anki flashcards out of everything you missed and everything you were uncertain of, you will end up with a monstrous Anki deck, because that's how medicine be. Repeating similar questions in a targeted drill set. Got a new preference for this one, guys. That's going to be openevidence.com. And if you haven't had a chance to try it yet, they are beta testing like USMLE prep, where you can ask for just generate more questions on like this subject, this system. I don't know how many subtopics, like I haven't seen how deep dive it goes with that, but that can be a good way to just drill similar ones. Or as I was mentioning earlier with the Chat GPT, some of the prompts I use of just how could this case be presented, similar but differently in the future. That's just a little favorite word of mine, phrase from like content development that AI models will have picked up on is similar but different. So when I was originally in content development, you're like, how do you make a good question? They're like, well, you see the official test maker stuff? And you're like, uh-huh. They're like, make ones that are similar to those, but different enough that you're not plagiarizing it. Go. And so that's basically how I was trained. And that's just what you can ask ChatGPT to do for you here. Okay. Videos, those should be used sparingly. And these are really, guys, where you have like a fundamental knowledge gap still. That's the time to go fill it in. And it's okay to have those. There is so much info in medicine. We're all going to have knowledge gaps. After I finished medical school and had, done my little bit of residency and then stopped and then started doing Kaplan stuff, at that point, I happened to just feel like getting a Boards and Beyond subscription and seeing what it was about because it had developed after my time. I watched all 13 hours of the guy's cardiology videos because he was a cardiologist. And so I was like, well, if I'm going to listen to you about anything, it's going to be what you're best at. And I understood cardiology better after that guy's step one videos, and I already had my MD at that point, right? But it's like, oh, I came back around to this, and it was explained a little differently, and I clicked things into place differently. And so just understand medicine is going to be a continual process of learning and relearning and deeper diving and building on your prior scaffolding, and all of that's okay. Next poll, please. Motivation check. What is going to keep medical studying interesting for you during dedicated? So this gets back at that original question of like those who are concerned about burnout or keeping their motivation up. The main thing I also try and remind my students of over time is you are learning really cool shit. Like, it is hard when you're in the weeds to appreciate just how much knowledge you're synthesizing in your brain and you can understand and explain. in ways that you never could before. And so just think back as you're going through this again, not about where you left off at peak of everything, but say you're missing some questions, Logan. A nice mental exercise can be like, man, I got a 30% on this right now. How would 1 year ago Logan have done on this? Even if he got a 30, from just picking C's or something. How would 2 year ago Logan done reading this? It would have looked like a foreign language to that guy. And so that's how you can really, I think, better appreciate from a metacognitive perspective just how much you're growing as a person if you allow yourself to one, not just compare yourself day to day, because that's going to vary. So is week to week. But if you think about it month to month or year to year, you're completely different people, knowledge wise and skill wise, than you were 1 year ago, and way more than 2 years ago before you started medical school. Appreciate that and don't take it for granted. Real patient correlates, absolutely. When I'm working one-on-one with students, I don't mind sharing my history and being like, hey, yeah, my kid has this problem. So, my youngest has struggled with speech apraxia. That is a Broca's area. You can remember this because Dr. D's kid could always understand what he was saying, but couldn't say it back to him and would get super pissed off and would be like, because she was like, I know what I want to say, but it's just blah, blah, blah. So, that's a Broca's area thing. Whereas Wernicke's is understanding stuff. Um, my father passed from subarachnoid hemorrhage. It was the classical thing. He fell, hit his head. We went and got him checked out at the ED. Everything came back normal. Next couple of days, starts getting a little more confused. Starts trying, 2 days later, he's trying to use his phone to control the TV when he doesn't have an app for that. I know nowadays, but yeah, just like that ain't the remote. Day 3, he's slurring. Day 4, he's gone. Like, but you're gonna remember that progression. I've talked about it, and that was my dad. And it's okay. Real patient correlates drive this stuff home. Look for them, and you'll be amazed sometimes at your own ability. When I was a medical student, I helped a friend who had adopted special needs kids um, get to the right physician to make a diagnosis of weird mitochondrial disorders. Why? Because I was a medical student that happened to be studying weird mitochondrial disorders right when my friend was like, my kids are having these freaking symptoms and nobody knows what's going on. And I'm like, I I think it's this thing. Go see if like one of the neuro people know about like this. And sure enough, she got into like a Barrows specialist who had to deal with mitochondrial disorders and they both got diagnosed. Like, so don't underestimate yourselves. I also get to throw that one out there because I didn't work as a clinician super long, so it's not like I have tons of cool diagnosis stories. But hey, when I was a medical student, man, that happened. But yeah, all right, Logan, what you got for me?
Yeah, I was gonna say thanks for sharing the clinical correlate with family because I
Mm,
think one, it's very personal, but it also can be like a really good way to, like you said, remember these things. And it's weird how things happen too, because we've been in our repro block recently, and my grandmother, who's 86,
mhm,
has vaginal bleeding, and the
mhm,
first thought is, all right, postmenopausal vaginal bleeding, what do you have to rule out? Endometrial cancer.
right.
And sure enough, she has endometrial cancer. And it's one of those things where like in this situation, like, yeah, it's obviously, it's tough, it's hard to go through, but it's just a weird thing to see, like, those
Mhm.
correlations. And then in her case, it's lucky where it's probably old age that will get her before the cancer does.
Right.
So it's also best case scenario in that sense, but it definitely will now always drive that point home in my head for someone who's, younger than that, but postmenopausal and different things. So I definitely think that, like, those family correlates are super helpful, and
Yeah.
it's weird how it happens when you're learning about it.
Awesome. So yeah, look for those kind of clinical cases, those real correlates, and of course, even more so once you're on rotations, guys. Um, I know the school requires it to a certain extent, like when you're on rotations to log your patients and stuff. Don't just look at that as a mandatory thing. I did, and I kind of did like that sort of minimal logging necessary to like check the boxes. And in hindsight, I truly wish I had spent more time like diagnose or like writing about my thought processes as I was working these patients up and what things I wish I had seen sooner or done differently for the future. Um, that I think would have really helped solidify a lot more concepts for me over third year, especially. All right, let's go ahead and jump to poll 12. We're getting near the end of them, guys. I made 13 for today. I would love to hear in the chat after we've gone through them how you guys liked this polling process because this is my first time running an event poll driven and not just me like having an agenda of slides, which Amy and AP have sat through a few of those. So, of course, again, all of these are going to be important things, even though we were just asking what you thought was most important. Consistency is the number one thing. If students ask me, like, what's the best thing I can do to, like, secure that I pass step one, it's not any, like, do this resource, yeah, just use boot camp and UWorld, just do this or that. Like, it's the consistency. It's taking the small steps every single day that you can. And as many of those small steps as you can get yourself to do, and keeping it up every day and not getting burned out or spun out and, allowing yourself to like just break your flow in progress. But a lot of that comes from students who don't know what milestones they're looking for along the way. And you're just doing stuff. And, I talked with this a good deal to Izzy and really any of my students who come to me after studying for a little while first. The first thing I do is go back to square one. Because after you've been studying for months, you've gone through the bread and butter stuff, and you're into these rabbit holes now. And you're spending your day looking at like optho and derm and histo stuff. And, first thing I'll do is sit down with a student and do an anatomy and physiology cardiac only quiz and just see how they do on that. And usually I find there's some pretty decent gaps there, and they're like, oh, I knew this stuff. I knew this stuff. I knew this stuff. Now I'm not because I've been studying all of these other in the weeds things. So, best thing, number one, is understand you are aiming to know enough. That's one thing I stress a lot, right, Izzy? Is we're not going There is always more. Always. You are aiming to know enough of it so that at any given time, you can sit down and they can throw 40 at you and you could get 70% of those right, no matter what that set is. And that comes from not knowing all these minutia, but being able to deliver on the bread and butter stuff time in and time out. And you'll find you could do 120 questions and it'll be like, oh, you got a 33% on derm. And you're like, oh no. And you look and there was three derm questions and you got one correct. And the other one you were close. And then the third one you weren't going to ever get right anyways. And you could be like, oh, 33% on derm. I'm going to go study that a shit ton. And it doesn't turn into more points next time. Versus you could go and look and be like, oh, I got a 50% on cardiac. And then you look and you're like, oh, 16 questions out of the 120 were cardiac questions, meaning I missed 8 cardiac questions here. And a lot of it is stuff that I could have gotten right. That is where you improve your score more for next time. So don't just look at the percentages, look at the yields. And again, just take those small steps every day, but don't get so in the weeds that you lose the big picture. Cardio, pulmonary, renal, those are the major systems that drive everything else in the body. And they're going to be, again, 20 to 25% of your questions every time. My whole shtick was I could pull an 80 in my CPR and make up for a lot of other stuff. I have told Izzy time and time again on the histo questions, that's a pretty picture. What does the story say? Because I can't read histo slides for shit. And I never cared because the pathologist person does that. I'm not even there. They're not asking for my preliminary read like on an x-ray. So I want to know how to read an x-ray and an ECG because I'm doing preliminary reads on those. Path does the path. They can do the path. I don't care, man. Just tell me what I need to know. So, but that's fine. That can pull you through. No offense to those who love histo or our future pathologists. We need you too. So yeah, the rest of it though, the consistency comes from the schedule. Have your sleep times set and protected. Have your start time set and know what you're going to do at the start of every day. That can come with end of day planning, or that can come with Sunday planning for the week. But you want to make sure first thing every day that you're setting yourself out to do is a set thing. For me, I like to start with questions. Let that drive what you focus on. So, okay, I want to work on some cardiac stuff tomorrow. I don't start with cardiac videos or just reviewing cardiac notes. I'll make a set of cardiac questions, see what kicks my ass versus what I'm feeling all right about. Go patch up some holes, do a little more cardiac, take some notes, move on to the next subject system. The other thing I would recommend is doing at least 2 different like subjects or systems each day. Don't deep dive one thing all day long and don't deep dive like the same thing day in and day out. You want to try and keep the topics mixed so that one, the spaced repetition keeps up and you're not getting too far away from anything. And then 2, just to keep it more interesting. Biochemistry is never going to be fun to study all day for the full day. So get it in little bites. I've been doing a biochem breakdown in the DDQX learning Discord where I've just been breaking down 1 page of first aid a day and just saying, here's what it's really telling you and what the major takeaways are. And a few active recall things to make sure you understand what this page is saying. Something like that. Tackling one biochem page a day versus, sitting down and feeling like you got to get biochem figured out when it's not something you like. Or if you just keep kicking that can, you're never going to get to that can. So that's my other advice. And then the next one is as you're going through each, don't finish out. Like, say you start with cardiac. Don't do all of cardiac in UWorld. Go through some of it, enough to make sure it's making sense and fill in some gaps and take some notes on where you could do better next time. And then move on to pulmonary and do that for a little bit. And then move on to renal. And then with the remaining questions you haven't used yet, start a mixed block. So once you've gotten through cardio and some pulmonary and some renal, and then you're on to GI, well, do some GI and then do a cardiopulmonary renal mixed block as some of your time. You get through GI and you move on to neuro, then do a cardiopulmonary renal GI mixed block. You finish your pass on neuro and go to endo. Your mixed block is CPR GI neuro. So that way you keep everything that you've gone through still fresh. You haven't gone through it all. You're still seeing some stuff on it. And that way, cardiac doesn't become the thing that you looked at 2 months ago and are therefore weak on. It becomes the thing you've been looking at for 2 months. See the key difference there. I studied the cardiac 2 months ago versus I've been studying cardiac for the full 2 months by the time I get to the end. That's how I prioritize these cardiopulmonary renal. We're going to get to the other systems. You're still going to study that and see it, but it's going to be a little bit less spaced repetition. That's why I say for the end, like psych and the ethics stuff, because you don't need a lot of spaced repetition to drive that stuff home. So, quick review before test day. Cool. We'll lock that stuff down. But your cardiac stuff that you want bread and butter, do it early and do it often. That's how you're really going to get it down. All right. Any questions or comments on the habits part here? AP, take us to poll number 13. It seems like everyone's kind of honing in on the same use. Homing in on, not honing. We home in on because we're a homing pigeon. Hone is something you sharpen. Just been corrected by somebody who was very particular about that in the past. So now I tend to always catch myself. All right. So yeah, everybody's like, hey, we should just be like, I didn't get this. What's happening here? Great use of it. Honestly, it's a feedback and logic checker predominantly for you. Now, the first one there, I do that for my students constantly. You got to be a little bit careful building the plans on your own without expertise, like or structure, like an expert structure behind it, because it could spit out a study plan that looks good 100 different ways. So I usually, when I make study plans for my students, it takes me 3 or 4 iterations because I'm like, all right, what's your first pass here at what they could do to get through all of this stuff between this date and this date? And then I look over that and I'm like, well, there's no room for spaced repetition in this. We need some full length practice. Or, yeah, I said to prioritize CPR, but you have them doing that for 3 weeks out of the available 5 weeks, which means they would not get to anything else. So, okay, let's think about that again. So you can use it for your study planning and stuff, but what I would recommend is gonna be a little bit of, um, well, one, I'm gonna send you guys out from today like an 8 week template that you can kind of use to build from, where it'll be like 2 weeks on capturing core concepts, 2 weeks on practice-based learning and scaling up your questions per day, 2 weeks on building the pacing and endurance, and 2 weeks on like bringing it all together with block and full length strategies. So that'll give you a starting point, and you can kind of adjust those 8 weeks accordingly from where you're at to your planned test date. But yeah, that at least again, you can use it if you're like, I already know I want to review this stuff this week, and I want to do 40 UWorld questions a day, and I want to have an hour each evening for Anki review. So the more you can put in some guardrails and guidelines in the prompt you give it, the better the study plan you'll get back. Otherwise, it can do a great job on analyses as well. I've had it ingest, I mean, I think it can do up to like 10 images at a time now. So I'll feed in score reports and be like, look for the patterns across these tests as well. So that's a nice one for me versus, I can easily look down one score report from a student, but if they send me three or four to pull them all up side by side and be like, where's the patterns versus when I can just drop them into the AI and be like, how are they trending on each of the subjects and systems? Where have they plateaued? Where have they improved? Where have they declined? Cool. Now that I've got that, let's build their study plan for this week to patch up those declines and see what we can do about the stables or the plateaus. So that's a good way of doing it. Um, Again, I would use open evidence if you're going to try and generate more recall questions or additional questions at this point over ChatGPT. Um, all right, and nobody was in the bottom three. So that's cool. I know there's some people out there who are like, I don't trust that AI stuff. It's going to take over the world, and if I ask it anything, it's going to know about me. One funny thing for me this year was that ChatGPT and the other AIs have discovered who I am over the course of this year. Like at the beginning of the year, if I was like, who is Dr. Brandon Deason? Or who is like, what's DDQX learning? It's like, yeah, I don't know. There's not enough info out there to give you an answer on that. And now you can ask it and it's like, oh, Dr. Brandon Deason is the founder. What it uses the language I put all the founder, CEO, and lead educator of DDQX Learning. Like, yeah, that's right, that's me. So, and then when I found that out, I naturally had to ask, would I be a friend or foe in an AI overlord apocalypse? And it said it depended on the type of AI overthrow. If it was a benevolent AI or that wanted like the best for humanity, or if it was a malevolent AI that wanted to suppress humanity, it said in the latter case, I would be on their radar because I encourage too much critical thinking and reasoning in my students versus just accepting what they're told. So I was like, I accept this output. Okay. And it also it did ask, as it does with its follow-ups, like, do you want advice about how you could be on like the friendly side of that malevolent AI? And I was like, why not? How do I get in its good graces? And it was like, okay, what you're gonna want to do is just teach them more to follow your protocol no matter what. And don't have them critically think each time, but just follow through on what you're telling them to do. And I was like, damn. Anyways, just wanted to finish with that little fun side. It is very helpful. Again, though, I use it as a reasoning check. You can use it to uh, even start post-morteming a bit. What would this, how else could I be presented with this kind of diagnosis? What would other questions about this look like? All right, that is all I had for the planned discussion. We can open it up, AP, to some AMA.
I'd say I have a question, decent.
Oh, what you
I
got?
have many questions. You know me. I have many questions, but I say, what is your motivation for doing what you do every single day? Because I've known you for 2 years now, since like June 2023, right? You know, fellow entrepreneurs working in this field. So like, why do you do what you do?
It's a good question. I mean, I have a relatively difficult business model that I operate with compared to others in that I try to solve pain points that students don't know they have yet. And because I want your lives to be easier. I was somebody who went through and did everything the hard way. Like I mentioned, had my kid during orientation week, added another one during third year because why not? Let's just, juggle some more. Um, I had my ups and downs, but I got through step one and dedicated. I got my score up to where I needed for step two CK to be a serious consideration for my specialty. I was able to secure fives in the rotations I needed to because of the way that I approached it, like both a learner and an educator, and saying, these people's job, one, I'm not here being a doctor. I am LARPing. I am live action role playing that I am a doctor. I'm going and pretending and asking the questions a doctor would ask and doing the moves a doctor would do and proposing the labs and imaging a doctor would order for my, plan of what I think a doctor would do. And then a real doctor looks at that and goes, yeah, that's not anything like I would do, buddy. Or they're like, good job, you role played good today. I give you a five. And so it's really about how are we perceived in our LARPing attempt. And so one of the main things I did to help me get fives in EM and IM was I'm like, when I go back to them and present this case, even if I do a bang up job, they're not going to just take what I say at face value. And I learned this like really quickly on some rotations, like EM, where I'm like CMP, and they're like, cool, why not a BMP on this patient? Remind me, medical student, what are the extra things we get on that CMP versus the BMP, and why do we need them now? And I'm like, well, this is what else it has, and this is why it's relevant to this differential. And they're like, yeah, that's right. I already knew that, but making sure you did too, and you didn't just tell me you wanted a CMP because that's more than a BMP is, and you don't know what's going on. So everything is you got to be able to demonstrate your reasoning, and they're always going to be asking you shit. So what I would do is like, hey, I just went and saw this pneumonia patient. They walk, talk, and quack like pneumonia. I know I got to tell them what other things it's not also going to be. But when I'm done presenting, what do I think they're going to ask me to make sure I know about pneumonia? Maybe they'll ask me about what microorganisms cause community acquired pneumonia versus the hospital acquired pneumonia. Maybe they'll ask me about which antibiotics would treat those community acquired bugs versus what I would need to do different with my antibiotic choices if it was hospital acquired. Maybe they'll go one step further and be, whatever. I just was about to finish that sentence with something else. Maybe they'll go one step further and say, what's the mechanism of like why this drug works on that bug? And so I would look that stuff up real quick because I was like, oh gosh, I don't remember my bugs and drugs off the back of my hand. So let's make sure I got that down. Cool. I went and present my pneumonia case, get through it, answer it's, most likely this, less likely these things. Sure enough, they asked me those same three questions, which is why I remember it to this day. Is they were like, all right, well, what? Yeah, this is, you think it's community or hospital acquired? I'm like, community, because they came from the community and not the hospital. They're like, good job. And then they did the what bugs, what meds, why? And I was like, ba 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 ba. And they're like, damn, this guy's ready to be an intern. He knows what he's doing. On it, that's a five. Because perception is 90% of reality on these things, guys. You're LARPing, show up and commit to that LARP. Do it, you know, as best you can and figure out how they present patients and mirror them. They want to see you doing what they do. And so that's what you're going to try for. All right. Any other questions? That's one of my biggest tips I give out for clerkships is, one, learn how they present. Everybody, like every specialty's got their own preferences for the one-liner. So how do they present? Make sure you're comfortable with that order. And then, yeah, if you ever get that chance between like I went and saw the patient and I'm pretty sure this is what's going on, and I at least have like a 2-minute walk to go back over to where the residents and attendings are, you should be really quickly thinking like if someone else were presenting this case to me and I'm trying to educate them, what things would I ask them as follow-ups to make sure they actually understand what's going on? I had already been a teacher and tutor. So for me, I was like, holy shit. As soon as I flipped that part of my brain on, I was like, that's exactly what they're doing. They're not jerks that are just pimping us for the heck of it. They're just actually trying to make sure we know what's going on and that we didn't just like, put on a facade of we knew what was going on. And so they're going to ask a few follow-ups. Well, if you get those follow-ups, then you can pull your facade a little bit further and look like you really got your shit on. All right, that's all for today, guys. If you were interested in the small group pilot, I will be following up with you asynchronously over Discord first. I'm gonna get my intake form out to everyone who is interested and see how well you all align on the intake form because I'm not trying to shove you all into a one size fits all program. I'm trying to be able to do what I do with my personalized one-on-one coaching with 4 to 6 students at once. So I want to make sure you're not all in completely different places with completely different time frames in mind. And I will get back to you guys on that. So thank you so much. I'd love to hear in the chat real quick, how did you guys like the poll responses as the leaders for each discussion?
Well, sponsors worked well. All right. Yes, it's we're all just theater kids. Yes, exactly. Correct.
Awesome. Yeah, that's what, I could talk about any of the bullet points I like had as those answer choices, but I wanted to focus on whatever concerns were highest to you guys or where you were seeing your biggest pain points. So awesome. Thank you for that feedback. Um, really thankful that you all joined us and it wasn't just me, AP, and Amy like pitching to cameras and talking a camera through it and for participating in the dialogue as well, especially, Logan and Izzy being on camera here and keeping our discussion lively. Very appreciated. So I look forward to chatting with you guys more here in the coming days and weeks, and we'll see what I can do about getting this recording converted and uploaded somewhere for the rest of the class to be able to see. Because I know everybody else likes to watch shit on 1.5 to 2 speed at a later point in time from when it occurred. That is the way of the world. So, to those of us who are later watching this at double speed, thank you very much. And I hope I was speaking fast enough. Are you? All right. Take care, guys.
Awesome. Thank you.
Thanks, everyone.